presentation. So I've been asked to talk about the antithrombotic strategies before, during, and after the procedure. So I will basically start with very easy slides about which antithrombotic strategy before the procedure, and then you have to ask two questions. One question, sorry, is the patient eligible for anticoagulation? If the answer is yes, usually you should stay on warfarin or NOAC until the procedure. And then when you do the procedure, the warfarin transition can be variable. You can let either the INR drift down naturally, or you can give a bridge with low molecular weight heparin. If the patient is on NOAC, and you've planned the procedure, you usually have to stop NOAC 24 hours or 48 hours before the procedure, depending on the type of drugs and the renal function. If the patient has a clear contraindication for anticoagulation, we usually recommend to give dual antiplatelet therapy before the procedure. And if the patient is only on aspirin, then you have to load with clopidogrel. And if he has no antithrombotic treatment, which can sometimes occur before the procedure, you have to load both aspirin and clopidogrel. So now, which antithrombotic strategy during the procedure? Then the common practice is to give intravenous heparin. It's usually recommended to give it before transeptal puncture to avoid thrombus formation on catheter and wires. And we should target an ACT level above 250 seconds. Can we do the procedure on warfarin or NOAC? There are clearly no data to support or dispute this particular approach. So I will base most of my talk on this aspect, which antithrombotic strategy following LAA closure. And the first question is, why do we need that? Of course, the answer is that we want to avoid thrombus formation, which is a very inconvenient complication in case of LAA closure. And we should ideally cover the time frame of device underutilization, but we don't have a clear idea. We estimate it to be between 6 weeks and 3 months based on animal studies, but this is something more difficult to assess in humans. What we know, however, is that when we close the appendage, the rate of stroke is rather low and on average below 3%. So we can speculate that the rate of, let's say, symptomatic device thrombosis should fit within the same range or even lower. And it's, however, very difficult from the literature to get a clear picture of the clinical impact of device thrombosis and also of the incidence of this complication. So in order to shed some light on this clinical issue, Dr. Lempereur from the University of Liège has performed a systematic review that we have submitted recently to a journal, and we have found in the literature 30 publications reporting 82 cases of device thrombosis, and the search was done until October 2015. And there was a total of 82 device thrombosis out of 2,118 implantation, yielding a global incidence of device thrombosis of 3.9%, with no clear difference between WATCHMAN and ACP. You see that the amulet has only one case reported in the literature out of 50 implantations. So the median time to diagnosis in this review was 1.5 months. So the diagnosis was made mainly in the early post-procedural period, although we had some cases that were diagnosed up to 2 years after device implantation. Most cases were diagnosed on routine follow-up imaging, mainly TEE, but sometimes also on CT or even transthoracic echocardiography. Very importantly, most cases of device thrombosis were totally asymptomatic and found during routine follow-up imaging. We found the occurrence of neurological events in only 6 of these 82 cases of device thrombosis, which consisted in 2 TIA and 4 ischemic strokes. So if you take the neurological events related presumably to device thrombosis, we have a very low incidence below 0.3%. And also, we found a significant correlation between the rate of device thrombosis and the number of follow-up imaging. The more TE you perform, the more you have a chance to find something on the device. Another aspect is that we looked at some risk factors for device thrombosis, and we could find several risk factors reported in the literature, including some patient characteristics such as high CHA2DS2-VASc score or CHA2DS2 score, or high platelet count, early discontinuation of treatment, or poor compliance. There are some echo findings, such as low ejection fraction, the presence of spontaneous echo contrast in the left atrial cavity, some procedural result, for example, too deep implantation, leaving, of course, a proximal cul-de-sac, which can be a room for thrombus formation, incomplete LAA occlusion, which can lead, of course, to thrombus formation, and also some specific risk factor related to the device, such as the presence of the proximal pin connector, as you know, which has been internalized with the new generation of the Appendage device. So now let's go back to the treatment strategy. which treatment strategy should we consider in a patient who has no contraindication to oral anticoagulation? If you look at the evidence, what has been published, we have to follow the Protect and Prevail protocol. And this applies mainly for the WATCHMAN device. And just to remember you what was this protocol, after implantation, all patients receive 45 days of oral anticoagulation with warfarin together with aspirin. And after 45 days and TV follow-up, if there was no significant peri-device leak or thrombus on the device, the patient was put on 6 months of dual antiplatelet therapy followed by lifelong aspirin. Of course, if after 45 days there was an issue with the LAA sealing, oral anticoagulation was carried on if necessary. And what to do now in patients with a clear contraindication to oral anticoagulation? Then we have some evidence from the literature. If we look at the ACP registry, again with the WATCHMAN device, this was a non-randomized multi-center registry which has included 150 patients with a very high risk of stroke and a contraindication for oral anticoagulation. The post-treatment strategy here was to give dual antiplatelet therapy for 6 months, followed by a lifelong aspirin. We know already the result of this registry, which was very good, with a low rate of stroke during follow-up, 1.7%, which was a dramatic reduction compared with what we could expect based on the CHA2DS2-VASc score. If we look now at the endpoint of this study, especially the rate of device thrombosis, there was one device thrombosis with ischemic stroke, so that's a symptomatic device thrombosis. But looking closer, there was indeed 6 device thrombosis, yielding an incidence of 4% for this particular registry. And then we have this single-center registry from the team of Boris Schmidt in Germany, when they have assessed the safety and feasibility of a 6-week antithrombotic regimen following LAA closure in 80 patients, which were divided 40 patients WATCHMAN implantation and 40 patients with the Implanted cardiac plug, and all patients had a very close TE follow-up at 6 weeks. And in case of device thrombosis, they adapted the antithrombotic strategy. So what they found in the patients who were successfully implanted, roughly 2/3 of the patients were on dual antiplatelet therapy and 1/3 on oral anticoagulation. And they found only 4 patients who developed thrombosis, which represent 5% of this study population, and in which they have just give an intensification of antithrombotic strategy, leading to thrombus resolution in all patients. So I think they have demonstrated that we can shorten the duration of antiplatelet therapy. That's a very interesting finding in this study. Also, the lowest rate of device thrombosis was in the DAPT group, which is strange because it was even lower than patients with oral anticoagulation. But again, it's very difficult from this low number of patients and events to draw a conclusion about the effectiveness of one treatment over the other. And then you have also this registry from Germany, from Dr. Menk, when they have implanted 60 WATCHMAN, mainly in patients with absolute contraindication to warfarin. And the originality here is that they have adapted the duration of dual antiplatelet therapy according to the bleeding risk, with 6 months of DAPT in case of low to moderate bleeding risk, and 3 months in case of very high bleeding risk. They had anyway 3 cases of device thrombosis, which were resolved successfully after 4 weeks of low molecular weight heparin. And if you look at the registry from Dr. Tsikas, which has been published in a Eurointervention last year, we don't have a clear picture of the duration of antithrombotic strategy, but it was recommended by the manufacturer to give dual antiplatelet therapy for each case 1 to 3 months after implantation. What we know, however, is that during the follow-up, during the last follow-up, the vast majority of the patients were put on single antiplatelet therapy, or very few patients were left on warfarin. So this gives some clue that during the follow-up, the vast majority of patients was not anymore on a strong antiplatelet strategy. However, this is a very difficult situation because we know from the active trial that once you give dual antiplatelet therapy, it carries almost the same risk of major bleeding as oral anticoagulation. So I think we should try, and this could be a subject during the discussion, to decrease the duration of this dual antiplatelet therapy. And you see here a very difficult case when you have, in the same patient, device thrombosis and an intracranial bleeding. So it's a very difficult thing to manage. So I think you have to discuss, to decrease the length according to the bleeding risk of the patient. So I summarize here the recommendation which are part of the expert consensus published and led by Dr. Meyer in Eurointervention. If you implant a WATCHMAN in a patient at very low bleeding risk, which means that he can tolerate oral anticoagulation, I think you have to follow the PROTECT and PREVAIL protocol. So it's 45 days of warfarin. If the LA has sealed completely, you can give 6 months of dual antiplatelet therapy and then lifelong aspirin. If you implant a WATCHMAN in a patient at very high bleeding risk, you have to give a dual antiplatelet therapy for 1 to 6 months, but I think you should tailor your duration according to the patient bleeding risk. And for the implant cardiac plug or the amulet, which have been implanted mainly in patients with contraindication to our anticoagulation, it's recommended to give 1 to 6 months of dual antiplatelet therapy and then to decide based on your personal experience if you have to continue aspirin or not. Many operators will stop aspirin after a short period of time. And what we need basically is a randomized trial. We need a lot of randomized trial comparing different treatment strategy, different treatment duration, et cetera, et cetera. We really have to set up this kind of study in order to tailor more precisely our approach. So which treatment now in case of device thrombosis? It's rare, but it can happen. Now you have to look at the menu. You have very different options. You can give low or high dose NOAC. You can give unfractionated heparin. You can give vitamin K antagonist. You can give low molecular weight heparin. Again, if we look at the review of Dr. Lempereur, we see here that the distribution of the treatment strategy for this complication, and it was basically 36% of patients were put on oral anticoagulation, mainly warfarin. And 45 patients on low molecular weight heparin, and the other treatment modality in 18% consisted in adding intravenous heparin, a combination of oral anticoagulation or intravenous heparin, or what they called an intensification of treatment, which was targeting a higher INR if the patient was already on warfarin, or putting low molecular weight heparin on top of DFAT. So we see that the median duration of antithrombotic therapy for this complication was 45 days with a minimum of 2 weeks, and a maximum of 6 months. And we see that the median duration of treatment was lower with low molecular weight heparin as compared to oral anticoagulation. There were only very few cases reported with the NOAC, only 1 case reported by Dr. Freksha with APIC7 with successful resolution of the thrombus, and 2 cases with dabigatran with only partial resolution of the thrombus. So we cannot recommend really NOAC until we have more data. And there were 3 cases of very large thrombus that could only be solved by surgery. So in conclusion, I think the duration and type of antithrombotic strategy following left atrial appendage occlusion should be tailored according to patient bleeding risk. The optimal treatment duration and combination for patients at high bleeding risk should be evaluated, I think, ideally within a randomized trial. And device thrombosis, as you have seen, is a rare complication of percutaneous LAAO occlusion. It occurs mainly early after the procedure. It's associated with a very low rate of neurological complication. In the vast majority of cases, the diagnosis is made during routine follow-up imaging. And anticoagulation, whatever the treatment strategy, seems to be safe and highly effective. And we need further studies to evaluate the optimal management of this rare but serious complication. Thank you very much.